Well, thanks so much, and thanks everybody for getting up bright and early for this session. So we're talking about Obamacare after Obama. You know, the Affordable Care Act, aka Obamacare, drove the most extensive reform, healthcare reform in the United States since the passage of Medicare in 1965, and some would say it's even more significant. Among other things, it provided greater access for millions of Americans, created a new tax credit to subsidize the purchase of health insurance, implemented insurance marketplaces all over the country, and drove innovations that favor value-based payment over fee-for-service. Of course, as we all know, it was not done without significant controversy and political resistance, which continues even today. But in this panel, we're going to look back and explore what worked and what didn't, and what we need to do to drive towards health reform 2.0. We're also going to look further into the future to look at newer, more game-changing models of healthcare, health system delivery and payment. So I can't think of two better people to have this conversation than the panelists this morning, and I'm just going to take a moment to introduce each of them. So I'll start with Ken Davis. Ken sitting immediately to my left here. Ken is the Chief Executive Officer and President of the Mount Sinai Health System. He's a leader in moving away from fee-for-service to population health, keeping more patients healthy and out of the hospital. As a neurobiologist, his research led to the development of 3 of the first 4 Alzheimer's drugs on the market. An elected member of the Institute of Medicine and author of more than 575 scientific articles, Davis is a highly cited researcher in the field of brain disease. His numerous awards include the George H.W. Bush Lifetime of Leadership Award from Yale University, and he's a trustee of the Aspen Institute. Dr. Ezekiel Emanuel, further to my left, is Vice Provost of Global Initiatives and the Diane and Robert Levy University Professor and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He was the founding chair of the Department of Bioethics at the National Institutes of Health, and he has served as special advisor on health policy, the director of OMB and Office of Management and Budget, where he played a role in the development of the Affordable Care Act. Dr. Emanuel has published widely on healthcare reform, research ethics, and end-of-life care. He's a contributor to the New York Times and author of the book, Reinventing Healthcare, which I have to say, unsolicited here, if you really want a good read on the ACA, I recommend that book.
I'll give you the $20 afterwards.
Yeah. No, it's every little bit helps. Yeah. So Zeke, just starting with you. Now, the benefit of hindsight, you look back and you say, gosh, from a policy perspective, not an implementation, we should have done this, or we shouldn't have done that, or we should have done this differently. What are you thinking about, how you might have done things differently? Yeah.
First of all, let me say that I think for all of us who were involved, and actually about 5 or 6 of us who were involved actually recently, like a week ago, had an email exchange, and everyone concurred, this thing has worked a lot better than we thought, and it's actually been accomplished a lot more than we thought at the time. But let me say, there's no hindsight. While we were doing the legislation, there were many things we wanted to do that we couldn't do for political or other reasons. So right out of the box, the legislation was a big compromise. You had lots of Democrats in the House and Senate who wanted things. You had the bureaucracy itself who wanted things. I'll give you my hit list of things that I would have liked differently. And I will start with payment reform. How we pay doctors, how we pay hospitals is the key to shifting the system away from taking care of people when they're acutely ill to keeping them healthy and keeping them out of the hospital. And many of us early on wanted a real strong push on that. I'll just give you my one example, which is bundled payments are where you pay doctors and hospitals together to get a unit of care done. A hip replacement, you have one price. The doctors, the hospitals, the rehab people, the anesthesiologists, they then figure it out. And we thought this was the best way of getting people to change payment, not just get fee-for-service for every little thing. I desperately wanted, written in the law, that we would have, by 2015, 5 of these across Medicare. I lost that battle. I think now Medicare has come along to the position that we do need those. We really should have had them. But lots of us pushed very hard to have payment change that was much more vigorous, much faster, right out of the box. So if you ask me, that's the biggest thing
Yeah.
that I really wish we had had before instead of waiting later.
Yeah. So Ken, right? So Zeke, an architect from a policy perspective, you're out in the field. You're running a premier tertiary care academic medical system, mission-driven, tough population. From your perspective, and I know you're committed to sort of value-based payment that was envisioned by ACA, but one of the things that you've kind of struggled with, you said, gosh, it would have made it a lot easier if it was this way.
Well, let's put this in a larger context, which is that American healthcare is a bigger percentage of the GDP than it is anywhere else in the Western world. And the macroeconomics of healthcare are driving change. I mean, a lot of the change that we would see every day is not just because the ACA says we're going to do something some way. It's also because the Blues come to us and they want it to be different. Aetna comes, United comes, everybody comes, and they want to get us off of fee-for-service medicine. So we're in a tremendous transition between fee-for-service to population management. And when we have some 6,000 doctors, not everybody's on board. And that transition is very difficult when we still have to maintain what our core values, which are, number one for us, making sure that your grandchildren don't have the same diseases as your grandparents, which says to invest a lot of money in research, and to take care of everybody who comes into our doors, no matter what their socioeconomic capacity is. And we live on the juxtaposition of two zip codes that have the greatest socioeconomic disparities than any in America. Across our campus is an enormous difference in people's ability to buy medical services. Yet our core value is that everyone gets the same level of care. And to do that costs hundreds of millions of dollars a year. So when we look at the ACA, and not just the ACA, but we look at other things that CMS has done, things called like the 2 midnight rule, which may be too arcane to go into, what happens to us is that over the period between 2013 and 2023, Mount Sinai Health System, which is 7 hospitals, will receive something like $2.3 billion less in revenues from the government. Now, that's a big number to absorb. And to do that and to maintain those values is an enormous problem.
So Zeke, one of the things we're seeing, right, is this really sort of shift in the industry, right? So the ACA appears to be a catalyst in sending very strong market signals. So we're seeing consolidation of health systems, we're seeing consolidation of insurance companies, even a convergence where insurance companies are acquiring or partnering with health systems acquiring plans. Is this, two questions. Is this a good thing? And did you ever imagine that the ball you started rolling would drive this kind of market reaction?
I think the answer is we did anticipate that the ball we would start rolling would create market changes and change how insurance companies worked and changed how healthcare systems work. And as a matter of fact, I think in January 2012, I had written the fact that insurance companies are going to have to change. They are going to have to partner with health systems if they really do want to get prices and costs down, and they want to be more efficient, and they want to keep people healthy, and that insurance companies are going to change in this company. They're going to get out of just passing the money around. So I think we did anticipate that. The consolidation issue, I think, is a major, on the hospital and health system side, is a major issue. I think there is too much of it. We have been trying to get, and a lot of this has to do with regulation, and we have been trying to get Medicare, CMS to issue different regulations that would actually facilitate competition rather than facilitate and incentivize consolidation. This is one of those issues that is, it's really in the weeds. Everyone says it's in the details. Consolidation is really driven in the details. Do you get paid more if you're affiliated with a hospital system than you do if you're doing the exact same thing apart from a hospital system? Unfortunately, that's true in a lot of Medicare. We've been trying to get them to have what is called platform neutral payment so that if you're a doctor in private practice or you're Mount Sinai, you get the same amount of money, for example, for giving chemotherapy or doing a hip replacement if you do it in an ambulatory care center as opposed to an academic center. I think that's important to make it financially viable and keep people, keep practitioners outside. Some consolidation is important, and we anticipated and wanted some of it because you need certain kinds of efficiency. You need certain scale to be able to deliver care at home, to deliver care across a spectrum, to take on the financial risk that Ken was talking about in terms of keeping people healthy. But I think we've also, in many markets, gotten to a point where there's too much. The Southern Connecticut market is a very good example where Yale totally dominates and there's no one else. And that's not a good thing across the country.
So Ken, you have a view on this and how you sort of balance the need for integration versus avoid monopolistic situations?
Well, one of the things we don't have to worry about in Manhattan is that there's any monopoly. We have between the brand in cancer and MSK and the brand in orthopedics and special surgery and NYU, Mount Sinai, and NYP, we've got 5 great hospitals and we all kill each other. So that's not our problem. But here's an interesting case study that happened to us. The continuum system, which largely has a lot of Medicaid, knew that it couldn't survive. 5 hospitals. And they looked for a partner. And the one partner that was closest to them in value was us. So we took on those hospitals. We did, hoping that the corporate savings would be enough for them to survive, because they knew they couldn't survive alone. Now, there were, of course, concerns that our consolidation would lead to higher pricing, and this was a terrible thing for New York. That's how the New York Times led the story. In fact, it's been far from the case, because our payments are still lower than NYP's and everybody else in New York. But without consolidation, those 5 hospitals would have never survived. And a lot of people would have lost the service.
That may not be a bad thing either.
Well, not for some of them it might not have been, because we in fact have shrunk one of the hospitals enormously. But for other parts of the system, it would have been a bad thing. 5 fewer hospitals in Manhattan would have been a bad thing. So, we have to balance here the ability for systems, for like some of these community hospitals, to survive versus monopolistic practices that Zeke alludes to, what happens in Southern Connecticut.
So Zeke, just to change gears a little bit now, so a lot of fist pounding over the last 7 years, Republicans threatening to repeal this and put in something else, and after years and years, finally just last week, they put their own plan on the table here. Just your view of, is it even politically possible to repeal this? And then what do you think of the Republican plan?
It's not politically possible to repeal the Affordable Care Act. There are 20 million people who've got coverage. Every insurance company has built its model on the Affordable Care Act. Every health system has built its model on the Affordable Care Act. Every drug company has built its model on the Affordable Care Act. It's not being repealed. I spent a number of hours reading the Republican plan. I would say that I found one good idea in there. I'm not joking. There was an idea.
What was it?
They want to, so for those of you who aren't into the arcane aspects of Medicare, there's Part A, which pays for hospitals, Part B, which pays to doctors. They've been separate since the creation. No insurance company runs that way. They suggest merging them with one set of deductibles, one set of co-payments and co-insurance. And that is an idea that I think we do have to go forward with. I would say the rest of it, my overall general assessment is it is not a coherent plan in the sense that it has a big idea and a big structure that all fits together. It's a lot of ideas that have been floating around in the Republican world that are, in general, been discredited, and I'll give you 2 particulars. So they recommend increasing the Medicare eligibility age from 65 to 67. That's 5.4 million people they're going to take Medicare away from. Okay? So then you ask yourself, all right, what's the substitute? Because these people need insurance. They're just at the point where they're beginning to get chronic illness, et cetera. You're not simply going to throw them off Medicare. So you've got really three options. One, they go on to Medicaid if they're relatively poor, right? States pay some of that cost, federal government pays that cost. You're not saving a whole lot of dough there. Two, they go into the exchanges, they get a subsidy to buy insurance in the exchanges. Oops, Republicans are getting rid of the exchanges, so that's not an option. Third, they go on to private. If they're still working, they get their employer to pay the bill. Or, of course, fourth, they get uninsured. Now, the estimates have been, of these 5.4 million people, between 400,000 and 1 million, depending upon what the infrastructure is, lose health insurance at 65 to 67. Employers are not going to be so keen about hiring them because they are higher cost. And you switch them to Medicaid. So you've got to call it 500,000, 1 million people uninsured who used to get Medicare. And how much are you saving? 0.2% of government spending, federal government spending on health care. Not a really smart deal. They also want to get rid of the mandate in the exchanges. They're against the mandate. Well, what about people who have pre-existing conditions? The most popular part of the Affordable Care Act has been, you got cancer, right? You've got inflammatory bowel disease. You've got some horrible thing. And either you lose your job or something happens and you don't have insurance. You can't be discriminated against. They can't deny you coverage or they can't give you coverage at an exorbitant premium. The American public likes this provision a lot. So what are the Republicans? What's their proposal if we're getting rid of a mandate and getting rid of the exchanges? We're going to have what's called high-risk pools. We're going to take all these very sick people and concentrate them in a product and then sell it to insurance companies. Well, let me tell you, what insurance company likes that? Only sick people. You can insure only sick people. Crazy idea. So what's it going to cost the Republicans to do that? $25 billion. And we know those high-risk insurance pools are terrible. We tried them early to bridge between the passage of the Affordable Care Act and when we opened the exchanges. And as one of my Democratic colleagues who worked on the Affordable Care Act said to me, they were one of our worst ideas. They just don't work. So they don't have a coherent plan. And everything they've tried, I think, has huge, huge downsides. It's either very costly for not covering a lot of people or increasing the eligibility for Medicare throws people off insurance and doesn't save a whole lot of dough for that valiant endeavor. I think it's going nowhere, absolutely nowhere. It's not a coherent replacement policy at all.
Tell us what you really think.
I said there was one good thing in it. I said there was one good thing in it.
So Ken, just shifting gears. So since the Affordable Care Act was implemented, we've seen now the rate of increase, the national of cost, coming down. And people were saying earlier, well, is it the recession? Is it the ACA? I mean, it seems now at least part of it is attributed to the cost reduction to the ACA. But as you look forward to say, what's out there looming in the future? Maybe not a black swan event, but maybe ostrich in the sand event. Where we're not paying enough attention to that could really derail us, right? That is, throw cost in the system.
Well, there are a lot. There are a lot. There is a subtlety that's going to kill a lot of blue state academic medical centers. And this is called DISH. Everybody's looking at me, DISH? Was it dinner? DISH is the disproportionate share payments. What you can think of them as something called like bad debt and charity. So when people come to the hospital and they have no ability to pay, there is a component from the feds called DISH, which made up some of that loss. So here's the story. The CEOs of the major academic medical centers are going down while the ACA is being developed, it's being written almost every week, and we're meeting with the staffers on the help committee. And they're telling us what's going on, and we're meeting with people on the finance committee, the staffers, and they're telling us what's going on. And also, I'm meeting with my daughter, who's a staffer for the Senator White House, and she's on the help committee. And everybody knows my daughter better than me when I go down there, but that gives me an ability to talk to people. So we're all talking, and it was a long night that the staffers had in the Finance Committee, and they say, we've just worked out what's going to happen with DISH. So we said, what's going to happen with DISH? And they say, well, you know, as we increase the number of people who are insured, we'll proportionally decrease your DISH payments. And we say, well, what are we going to do with the immigrants who aren't going to be covered? And this wonderful staffer goes, oh, the immigrants. And we say, well, California, New York, Texas, and Florida have a tremendous number of people who come to our hospital who are not going to be covered, who are either illegal or not going to be eligible. And she says to us, you remember what happened when the president gave a State of the Union address and he talked about that immigrants weren't going to be covered? That some House Representative Republican got up and said, you're a liar, at the State of the Union address. She said, we have instructions. We're not going to deal with the immigrants. So we say, you know, we can't have those DISH payments proportionally go down to the same degree as there are increased enrollment, because we got this group of people who are not going to be covered. They say to me, go see your senator. So we go to see Chuck Schumer, right? And Chuck sits down with us and he says, don't worry. We'll get this bill done, and then like every other piece of social legislation, there'll be add-ons afterwards, and we'll fix these things that we know have problems now. Well, we didn't fix anything. In fact, we made some things worse. So where we stand is we're still arguing over that. So that's hundreds of millions of dollars just to our hospital. But there are other problems. I want to talk about one other bomb that was in there that everybody realizes was a mistake and nobody can fix. And that's what's called market exclusivity for 12 years for biologics. What biologics mean, Zeke wouldn't have put this in. What biologics
Zeke was
mean,
definitely against it.
what biologics mean are the proteins and antibodies that you get by infusions. So this was the deal that the pharmaceutical companies made so that they would sign on early on to the ACA. They'd get 12 years of exclusivity because they were worried that biologics were going to go generic and there'd be generic competition. So what does that mean? I'm a neuroscientist. I'm interested in developing new drugs that are going to get into the brain. Biologics, because they're big proteins, don't get into the brain. So the big pharma companies all start to close down their neuroscience areas. And they focus more on the drugs that are going to have these 12 years of exclusivity, which, by the way, are the most expensive drugs. These proteins, because they say, well, it's hard to make the antibodies. These are the $100,000 a year cancer drugs. So what we're seeing is a disincentive for the diseases that have some of the most important morbidities, like Alzheimer's disease. Now, there are studies in Alzheimer's, and there's some hope that there'd be some of those antibodies. But by and large, this is a bad piece of legislation that is a time bomb for the development of drugs and has to be fixed.
So Zeke,
Can I?
Yeah, go ahead. Sure.
So I just want to, Ken and I are on the same page about the 12-year exclusivity. We fought it, and it was just, you got to get legislation through, and you make compromises, and not every piece of it is something you like. The big question on legislation is, net-net, was it better for the country? And undoubtedly, net-net, the Affordable Care Act is better for the country. I would say on the DISH payments, you and I do disagree in that the DISH payments don't go to zero.
They won't now.
They weren't in the bill. They go to 25% of what they used to be. That's the first point. Many of the Medicaid or poor people who didn't have insurance now do have insurance. And as a consequence, your bad debt, i.e. hospital services used that were not paid for on all hospitals in America has gone down tremendously, and hospitals are actually doing better as a result of the Affordable Care Act, even with the DISH decline. So net-net, you can complain about this little part, but you have to look at the whole picture, and the whole picture is you're actually doing better.
We're not doing better.
I saw an oi moment there.
We're not doing better. Well,
your uncollected bad debt has gone down tremendously thanks to the Affordable Care Act.
But remember, what's going to happen to the DISH payments, you know this is the bizarre thing that CMS is doing, is they're going to distribute it. The current proposal is to wind up distributing it to the states that didn't extend Medicaid. So the winners are going to be the red states who are against this bill.
The whole bill was always a winner for the red states.
That's right.
Well, all right. So moving off dish payments. When we look at cost and what is going up, it is drugs.
Yeah.
I mean, that's the one thing that seems to continue to be going up. And, Harvoni, for hepatitis C, $94,000 per course of treatment, 12 weeks. I mean, how are some of these very specialized drugs with very small market base, some of the products of precision medicine, is this going to be our future? And is there any way to stop this from happening? What do we need to do to get drug costs under control? I don't know, Ken, if you have thoughts about that.
Well, I think this is a very, very hard problem. And Zeke and I disagree on whether value purchasing or, qualities are the answer. I don't have a good answer to this. But I just am appalled at some of the things that are a consequence of this. A lot of our hepatitis C patients are Medicaid patients. And in New York State, Medicaid is a lot of now not-for-profit managed care entities. One of them is called Health First. Health First is losing a lot of money because of the cost of taking care of our hep C patients, which is then distributed among all the hospitals who are the partners in Health First. So what have we done? We've rationed the use of these drugs. And we give it to only the people with the very sickest liver disease, end-stage liver disease, or moving toward end-stage liver disease. So we cure those people. But what does that do for the epidemic? The healthier people who are hep C positive are all continuing to spread the disease. So instead of really having the resources to stop hepatitis C and end this epidemic like you might think for polio, because they say, oh, this is such a great drug, it's going to stop the disease, we can't do that because we can't afford it as a healthcare system. New York State can't afford it as a healthcare system. So we're not doing what's right for people. And I've said this in other venues. Imagine if we had done the same thing with the polio virus. Imagine if after the polio vaccine was developed, someone had said, let's figure out how much money this is going to save the system, and we'll charge for this vaccine how much money it's going to save the system. When I was in second grade, I got my polio vaccine, and my parents rejoiced that in my school, I lined up and got a shot. And we didn't have to pay anything for that shot because the government realized how important that was, and the people who developed it realized that this was in the country's best interest. Somehow, that social contract's been broken now. And we try to maximize profit every place we can do it in the healthcare industry. I can't do that in the business that I run, and I don't know why the pharma companies can do it in the business that they run. But somebody's got to realize that there are higher values that we all have to support in this country and not allow things like $100,000 pills because we say, oh, how much money it's going to save down the road for what are epidemics in the United States.
Switching gears one more time, because I want to get to questions in just a minute. So we've had this, the ACA is going to stay in place. It's going to continue to evolve. It's going to get tweaked. But when you look, say 10 years down the road, what are the sort of the next big things in sort of healthcare delivery? How are we going to fundamentally, we still have to take cost out of the system in a big way. What do you see as some of the really big change in how we're going to deliver care to people with chronic disease down the road?
First of all, I'm actually wildly optimistic about the future of the American healthcare system. Yep. It does have a cost problem. It does have a quality problem. It's got lots of problems. But the amount of brain power that is coming into healthcare between startups and people really reimagining how we're going to deliver healthcare is second to none, and really I don't think has occurred since the Flexner Report, which is 1910. We really have people who never thought of healthcare now getting into it and really rethinking it. So if I had to say the one big idea that is going to be transformative about healthcare over the next decade, I would call it deinstitutionalization. We are going to be treating more and more people out of hospital, people who were the bread and butter when I was an intern. They have an exacerbation of emphysema. They have an exacerbation of congestive heart failure. They have diabetes problem. They have pneumonia. We're going to be treating them at home at a much lower price point, much higher quality, in a place that they like. That we've got a lot of experiments in hospital at home, and that's going to go big time when we get an infrastructure that allows that to happen much more broadly. That's going to bring down the number of people in hospitals, and closing hospitals is going to become much more common, which I've predicted will close 1,000 hospitals in this country. That's one aspect of deinstitutionalization. And again, I'll just give you one example. If you want to take people with hip replacements, you can do it really efficiently, and a lot of those can be done not in the hospital but at ambulatory care centers. You discharge them, and they go home and they get their rehab at home rather than in a skilled nursing facility or some rehab hospital. Saves a huge amount of money. We know, we've just done some studies that between getting cheaper implants, getting cheaper artificial hips, and not treating them at these facilities can save at least 25% off the cost of a hip. And probably if you migrate a lot of them out of the hospital, you'll save even more. That's going to become just the routine. And I think that is going to make healthcare much, much better. And then the next phase of it is the office visit is also going away. The notion that doctors have an office and you go to the doctor, I think, is going to go away. That's going to be a little more than 10 years. But delivering care where you are, for chronic patients, delivering it in their house. And again, we have early experiments now that show with people with multiple chronic illnesses, going to their house rather than having them come to your physician office, interacting with them much more frequently, putting technology around to help the care providers. That also can save money, keep these people out of the hospital, keep them out of the emergency room, and you save costs on no bricks and mortar.
Let me ask Ken, you run a hospital system, you buy that vision of the future, and what does that mean for you?
Well,
are you getting ready for that future?
Yes. I mean, we just announced how we're taking one of our hospitals in downtown Manhattan, and when we rebuild it, a hospital that was once licensed for 825 beds, that today have 400 beds filled with patients, is going to be, when we finish building it, we'll have about 200 beds. And in parallel, we're going to be spending over $500 million building up the ambulatory platform below 34th Street. But to answer your question, when I look at the future and I think of what has to be done, I think that unless we address two issues, we're going to have a bankrupt healthcare system. And those two issues are the chronic diseases like Alzheimer's disease and type 2 diabetes, which are just costing us enormous amounts of money and we're not really finding the treatments for, and how we deal with death and dying. I think these are very, very important issues, and connected to one of those type 2 diabetes issue, is are we going to start to treat high fructose corn syrup and sweeteners in our diet like we did tobacco? Are we going to let the adolescents that I see north of our hospital continue to develop type 2 diabetes at age 16 or 17, which we never saw 20 and 30 years ago? I think if we don't start to get control of these chronic diseases and the causes of them, and to develop some treatments for them, as well as deal with death and dying, we're not going to really address the cost drivers. We say, how are we going to bend the cost curve? Well, those are big cost curve. Those are big components of the cost curve, and we're not addressing those aspects.
Well, wait.
Okay, quickly, because I want to get questions.
Yeah.
Yeah,
First
very,
of all,
very quick.
on the diabetes side, we have had a national conversation that has changed because of the First Lady's Let's Move initiative. We are much more aware of obesity. We are much more focused on it. And I want to say that Philadelphia just passed its soda tax, which I think is a major step forward. And again, one of the interesting things, we're going to obviously have to study its effect on diabetes and obesity, but one of the major things it did is it ran the campaign not on we're going to improve health. We need revenue to improve lots of other things, like early childhood education, which we know will have a compounding positive effect on improving health. And I would say on end-of-life care, which is an area I've worked on for these 30 years, since the mid-1980s, one of the original researchers on it, the glass is definitely both half full and half empty. It's half full because we are treating people at the end of life much differently today than we did in the 1980s. Just to give you one data point, cancer, in the 1980s, 75% of patients who had cancer died in the hospital. Today, it's under 20%. That's a big shift. Does that mean we've solved the end-of-life care problem? Absolutely not. But there are also lots and lots of smart people addressing it. There's a company which I'm involved with out of Nashville that has got an amazing set of interventions with palliative care nurses going to patients' houses and intervening early, about a year before the death, and able to bring down costs 50%. Again, this is an area of tremendous innovation and activity, and I think over the next 10 years, you are going to see much better end-of-life care in this country, and we are focused on it. And I am quite positive about that transformation. Alzheimer's is a totally different story, which I think it is the frightening wall out there that if we run into it and we don't have a solution for it, it is a total car wreck.
Well, hope your company's a success because we need it. We need more of them. So, okay. So now time for audience questions. One right out of the gate there. I'm going to pick 1, 2, 3. And stand up, state your name, one question per customer.
Yes, one question. Good morning, Catherine Phillips. And 3 years ago, I put my money where my mouth is because I happen to be a professor of health economics. And I got a high deductible health plan. And for the life of me, I cannot figure out how it works. 3 years later, I'm still trying to figure out how it works. And what I worry about with the ACA is that these people tend to have high deductibles, and people don't know that. So we want these consumers to try to shop. And I can't shop, and I have a PhD. So the only thing I can think of to do is to have more preventive services covered without a deductible, so people do not have to choose. What do you think the solution is to this?
You're each going to get one. So I'm going to go. So pick which one you want.
First of all, let me say the high deductible health plan is, the thing Republicans push endlessly. That's their model, right? Get people to have more skin in the game, and they will use less services. We know that's true. They do use less services, but they use less necessary and unnecessary services. People aren't good at differentiating it. And I'm in your boat. I signed up for a high deductible plan, and I do have a lot of letters after my name, and I'm just like you. I can't figure it out. I think actually the solution to this problem is we need better software on the exchanges and when you're buying insurance that helps you understand what net at the end of the year your costs with premiums, out-of-pocket payments, and deductibles and copays is going to be. That software exists. One of my frustrations with how the exchanges have been implemented is they haven't been as good at getting, the best consumer-facing software out there on the exchanges for people. And I'm hoping that the next administration really focuses on that because it's out there. There are lots of great computer software developers who have that technology, just hasn't been integrated smoothly into the exchanges. And then it'll go from exchanges to the employers. We really need that.
Okay, next. I picked somebody. Who did I pick? Somebody I pointed to.
Hi.
Okay.
Mine is kind of a follow-up to this lady's over here. Over the past couple years, my premiums have gone up 50% with a higher deductible. And so I'm effectively uninsured except for major catastrophe, okay? All the doctors that I know, none of them like the Affordable Care Act. They all make less money every single year. And personally, I want my doctors making a lot of money. I want them to be happy to see me. So why is that? And I wish that there would have been on this panel a person half as eloquent as you are that could have argued against some of your points, which you make very well.
I think that's directed to you. I tried to.
Well, look, if you actually look at the overall data, and I think was said before, the actual per-person costs on healthcare have moderated in a way that they haven't moderated in 50 years. And almost everyone is seeing increases in their insurance premium. And that's not because healthcare costs per person have been going up. What you're seeing is a shift by employers of who's paying that bill. And it's been well documented that what employers have done is actually decrease the amount they're paying for health care and increase the amount that the worker's paying for health care, even when the increase in the premium is low. And so what you're experiencing is not a result of the Affordable Care Act, it's the result of the way employers have decided to minimize their financial risk. Just as we know they're making huge profits and keeping wages low on a lot of workers, the same thing is working on the insurance side of things. Basically, it means, and I think Ken alluded to this, we've seen in this country, we're not going above 18% of GDP. That seems to be the limit that both the federal government and employers can tolerate. And their solution to that problem is to shift more and more costs onto workers, even when the bill is not actually going up that fast. I wish I had a graphic I could show you that actually since 2010 to 2014, the last year for which we have reliable data, we've actually bent the total premium cost. How that's distributed between you and your employer, that's something the Affordable Care Act actually doesn't control.
Well, one thing that I want to say about this, that I'm sure doesn't affect you, but you read about in the newspaper, is the discussion of how much the premiums are going up on the exchange. And what we should understand about how the exchanges were put together was part of the compromise in the bill when we had mandates was how much would the penalty be and when would the penalty come on. So what's happened to the pool? What's the actuarial pool look like? Compared to people who are not enrolled, who were previously enrolled in insurance, compared to people who are now on the exchanges, there's twice as much diabetes on the exchanges, there's 3 times as much HIV, and there's twice as much Hep C. So what you've got is a pool of people who previously couldn't get insured, who are now very sick, and that well people looked at the penalty and they said, what do I need to join this for? So you got an actuarial pool that's a terrible actuarial pool that's a result of the compromise in democracy that happens when a 2,700-page bill is written.
Next.
Wait a second. Wait. 906 pages. Don't do the usual BS of 2,700.
I had the third person who I pointed to before. All right, this gentleman here. Do we have a mic for him?
Good morning. Michael Stubbs from LA. And for full disclosure, I serve on Zeke's advisory board at Penn. A quick question.
Direct a question to him then.
Well, it's actually for both of you because you both spoke of care at home and you spoke about excess hospital beds. And I'm wondering about intersecting crises in this country around homelessness at the same time as a dearth of psychiatric beds. And if there are surplus beds, what can we do about those beds? Can we please treat our homeless and people in need of psychiatric care?
So,
Ken, can you pick that up?
So when we look at the advances that we see in medicine over the last 20 and 30 years, when you look at things like laparoscopic surgery and what it's done to length of stay, when you look at all the advances that we've had in drug therapies, what has been largely left out of that are brain diseases. When I started in this field, there was a breakthrough in biological psychiatry that was a lot of happenstance, new drugs, that mechanism of action was surprising, but we thought that over the next 30 or 40 years, we'd have better antipsychotics, we'd have better antidepressants, but we don't. We don't. In fact, what we have is a lot of legislation that deinstitutionalized without funding the ambulatory platform that was necessary to keep people well in the community. So when you have no scientific advances, no therapeutic advances, and you bankrupt the ambulatory system, not surprisingly, you've got a lot of homeless people. We have more people incarcerated in prisons and more people homeless than we have in psychiatric beds. So when we closed down that hospital that I talked about, shrunk it from 825 beds to what's now going to be 200 beds, we didn't take out a single psych bed. Because that's what I believe in. And we're also going to be integrating more ambulatory care with our inpatient facilities. And when I spoke to our governor, Andrew Cuomo, about this and what we were going to do, he said, Ken, the most important thing that we have to do is make sure that we develop a model with you for how we're going to take care of the mentally ill, because we don't have an effective model. My view is we won't have an effective model until we put more money into the ambulatory side and until we can encourage the drug companies again to start doing brain research and develop really new breakthrough drugs.
So I think we need...
Quick, I want to get it more.
We need the full spectrum. And I'm actually, again, this is one area where I'm quite optimistic in the next decade, beginning in 2020. We've spent the last 30, 40 years carving out mental health, sending it away, hiding it, trying to not deal with it. And I think the next phase is we're going to realize that you can't solve chronic disease problems, you can't solve lots of the problems of homelessness without actually integrating mental health into primary care. And that is going to be the wave of the future. So we're going to, I think, develop a full spectrum. Some people need asylums because they're dangerous to themselves or dangerous to others. They can't be out on the street. But the wide middle will be much more cared for by primary care doctors with psychiatric and actually psychological and psychiatric social worker backup. That's where it has to happen and integrated right into primary care. We have a lot of good models out there in the country, and what has to happen is they have to spread from the isolated experimental models more broadly.
As a psychiatrist who doesn't share that optimism, I only can think of a line from Bob Dylan about what the next 10 years will look like that would happen. He said his name was Columbus, and I just said good luck.
He did discover America.
Who is this gentleman here, and then this lady here, and then that man in the back? If we was going to have quick answers, though. Quick questions, quick answers. We're coming down the home stretch.
My name is David. Quick question. As you listen to some of these other questions, there's a disconnect between what people believe, what you're saying is Obamacare is positive versus what people here on the ground are feeling. Can you give us 3 quick talking points when somebody says Obamacare is horrible, and what can you come back with to counter their argument? And not that facts mean anything to people anyway, but give us a couple facts.
So I would say the following things. First of all, if you're interested in access, how many people get coverage? The Affordable Care Act has gotten 20 million people coverage in a variety of ways, not all through the exchange, some through expansion of your health insurance to age 26. That's been a huge positive. Second, historic slowdown in healthcare cost growth. The facts are that we've actually slowed the amount of money we're spending in healthcare in a way totally unpredictable. The Congressional Budget Office got it wrong. Almost all of us, pinheads in Washington, got it wrong. That's had a major, major impact. Actually, federal spending, there's a recent report 2 weeks ago, federal spending over the next 10 years because of the slowdown in healthcare costs is going to be $2.6 trillion less than anticipated as early as 2010, saving a huge amount on the federal deficit. And the last thing I would say is, you hear all the time, oh, the Affordable Care Act, job killer, job killer. Employers aren't going to hire because of the Affordable Care Act. There is not one shred of evidence that that's true. Employment has gone up after passage of the Affordable Care Act consistently, and it has nothing, the dips and rises has nothing to do with it. And the last thing I would say is the Affordable Care Act actually lowers the federal deficit, okay? Built into the act is the fact that over $100 billion, okay, we're going to take $100 billion out of the federal deficit. We're collecting more money, okay, spending it more efficiently, keeping costs down, and the result is actually a decrease in the deficit. So you've got an increase in access to care, slowing down of healthcare costs, decreasing the deficit, and no effect on employment. What better legislation can you get in America?
2 minutes.
What I see is people complaining about the Affordable Care Act, Obamacare, don't understand what they're really complaining about is health care in general, and what's happened to health care costs in general, and what's happened to the practice of medicine in general. They see a lot of complaining doctors, and they think it's Obamacare, but it's really the macroeconomics of health care. Because what this bill was supposed to do was increase access, improve quality, and decrease cost. And in fact, it's done all those 3 things. But look at this audience and ask, how many of you people are on the ACA? How many are on exchanges or on Medicaid? It's nobody. I mean, there are 13 million, those 20 million are Medicaid patients. That doesn't change what's fundamentally happened in America. And 7 million are on exchanges? I mean, that's a pittance of the number of people who are getting health care in the United States. What we are complaining about, not inappropriately, is that there are a lot of problems in health care. There are a lot of issues in healthcare delivery. And what we hope is, as we move off of fee-for-service medicine and ultimately get to population management, and we have more invested in prevention, and we have more of these hospital at home, we see more ambulatory platforms, and we begin to realize that the changes are not catastrophic, that closing your community hospital is actually a good thing, we're going to realize that, you know what? We're getting better care now. But don't blame what's a small group of 7 million people on the exchanges for changing what's happened to healthcare because we can't afford it economically in the United States.
So he's diligently taking notes so he can get off that. I would recommend you get
Talking points.
I would get Zeke's book, actually. It is a very detailed and very readable sort of primer on the act, and it's really well done. Unfortunately, a lot of good questions out there, I'm sure. We are out of time. I would ask, I don't know if our guests can stay, panelists can stay a couple of minutes after to answer questions, but thank you very much for coming, for your very thoughtful questions, and have a great day. And thanks to our panelists.